This is Talk with Audrey. My guest is Dr. Stella Safo. She's an internist and primary care physician based in New York City, and she's Chief Clinical Transformation Officer for Premier Applied Sciences. She received her medical education from Harvard Medical School with a master's degree in public health with a focus on global health at the Harvard School of Public Health. She completed her residency in primary care and social medicine at Montefiore Medical Center in the Bronx, and subsequently completed an HIV Clinical Scholars Fellowship with HIV Medicine Association at Montefiore. And she's received some honors. They include the 2018 Award for Community Advocacy in HIV Medicine from the New York Department of Health and the Women's Advisory Board, and induction as a fellow in the prestigious New York Academy of Medicine. And this year, Modern Health listed her as a top 25 minority leader to watch. Welcome to Talk with Audrey.
I'm so glad to be here.
Thank you for joining me. So, Dr. Safo, I am trying to give my listeners as much information as I can because we're all hearing so much and it's hard to decipher what's true, what isn't. And I understand you live in Harlem. You're from Ghana, raised in Brooklyn and Long Island, live in Harlem. So you're very familiar with New York specifically, and I'm sure you're in touch with your colleagues worldwide. So where are we now in terms of fighting COVID-19?
Yeah, I think it's great to start with level setting. So, I think at this point, we all know that it's a worldwide pandemic. I think what's so interesting is a lot of times when we have something that's kind of going from country to country, you anticipate that developed countries will get ahead of it, will have the equipment that they need, will be able to kind of handle it, and that'll be the kind of global south and developing countries that'll really struggle. And I think COVID has shown us that we're all vulnerable because COVID, yes, it's a disease that hits individuals, but it's the way that it spreads, it really does hit your infrastructure and your system. So to your question of where we are, we really find ourselves unprepared. The U.S. had about 3 solid months from our first report of cases coming out of China to prepare ourselves. Preparation would have looked, like us getting our personal protective equipment ready, our testing ready, preparing public health officials. And we basically, to not be too precious about it, we basically failed in doing that. And so where we find ourselves now is really struggling to catch up with this virus that is, it knows no boundaries and is really ravaging our healthcare systems. In New York City, we're seeing that surge of patients come in who have COVID and are suffering from various, end organ damage from it. And so they're being put on ventilators. The numbers of patients that's hitting means that essentially what's happening is we can't keep up with the load. Yesterday alone, we had 15,000 COVID-related hospitalizations. That is an unprecedented number of, simultaneous hospitalizations to be happening in a health system, in any health system. And so we're basically in a place where we're suffering, and that suffering is happening worldwide. And I think one thing that is starting to happen now is we're starting to see the way it's hitting different communities. And so I think there's a lot that we're going to be learning, but everyone's in this together, absolutely.
So you mentioned that we were unprepared. When you say we, right, I know you're probably speaking more in terms of as a country unprepared. Yeah. Hospitals, on the other hand, how could you have possibly prepared without information and the resources necessary in order to take care of this huge influx of patients that you're receiving? Yeah,
and so, it's a good point because there's no way. Hospitals kind of do a couple, and especially hospitals in New York, we do a couple of levels of different kinds of, mass casualty preparedness, where they'll run us through drills of, if we have a terrorist attack, here's what happens. If we have, other kinds of natural disasters, here's what, happens. If we have, a few years ago, we had Ebola as a crisis, and we went through kind of some preparedness around that. So there's kind of, I'll call it initial reaction to emergencies that we're set for. But what is so interesting about COVID is that COVID isn't something like, like a mass shooting or like 9/11, right? That hits you and is impacting the city for a week and a half in terms of its intensity of numbers. This is something that, is going to hit you for weeks. And so this is a perfect example of how your local environment's important, but absolutely our federal policies really matter. Because there's no way any hospital could have prepared for the impact of this. And so what these hospitals have done is their short-term preparation has helped. For example, they have the communications in place, they have the teams, the emergency preparedness teams that are kind of ready to go. But the long-term needs, which are getting supplies, getting equipment, having enough staff, that's above most of the pay grade of these local environments. That's when you need the strength of your federal government. And we don't have a federal government that's supporting many of our local efforts right now, sadly. And so what you're seeing is people really, really scrambling. I think there are many great people in our federal government that are trying to help, but is it coordinated in a way that can really meet the needs of our health systems on the ground? As a provider, I would say it doesn't feel that way. And so maybe eventually it'll catch up, but for now it really does not feel that way. And so no, we couldn't have prepared more than we did, and we're just not prepared now.
So let's talk about for just a minute the emotional impact that caring for such huge numbers of people without the PPE that you need in order to protect yourself as well, because it is true that if doctors and nurses and surgeons, medical personnel, who cares? If you become infected, you can't help anybody else, right?
Exactly.
So
right.
Talk to me about how some of your colleagues are dealing with their own emotions as they just try to do what they do best, which is to save lives, but with knowing that they too might become infected.
Yeah, I mean, it's absolutely devastating. That's the part that really didn't have to be this way. We knew that a pandemic would come and it would be terribly hard to deal with. I don't think anyone anticipated just how much our lack of preparedness would add to it. And so if you imagine a clinician, they have a very hard job to do to go and evaluate these patients. The job becomes harder to do safely if you feel like you yourself as a clinician are not safe. You don't have a face mask that you can change between patients. What's happening is we're getting, supplies given to us that we have to use for the entirety of the shift. I'm hearing some colleagues are using their supplies for, the entirety of the week because they're not getting these supplies. It just aren't enough. So if you don't feel kind of personally safe yourself, or you're watching other colleagues get sick, then really you're not able to be at your best when you're treating your patients, right? And even more than that, you don't get to go home now at the end of a shift and just go home. I'm hearing about people who are sleeping in their cars or trying to find other places they can sleep at so that if they are infected, they're not infecting their families. So you're not getting that kind of rest that you would get at the end of the day. Your colleagues are getting sick. You're getting sick. You don't always feel like you're being protected. Exactly as you described, it's a perfect storm. So it then kind of, makes us think, well, what's going to happen in the short term? I would say in the short term, people are resilient. We're going to do what we have to do to get our patients through this, to get ourselves through this. We're going to kind of rely on each other. You've seen these stories of people flying from different parts of the country to come to New York, come to where it's needed and really help. That is like the beauty, I think, of colleagues and Americans, and we're all kind of pulling together. I think the real challenge comes when this is all done. When the kind of intensity of the response is quieted down and people have to start reflecting on the decisions that they were forced to make because, for instance, there weren't enough ventilators. And so, you had to follow your hospital protocols to choose who got the ventilator and who didn't. And, some of those decisions being on the front lines will haunt some individuals for their lifetimes. Physicians have some of the highest rates of suicide in this country compared to other professions. And so I just am really concerned that when this is all said and done, those rates will go up even more, and we're going to see the impact of this down the line. So I think it's a really good thing to start thinking about now. How are people prepared now to deal with this crisis, but also when this is done, how do we make sure that we take care of the mental health and kind of post-traumatic stress that many individuals are going to be left with because we didn't send them into battle against COVID with, everything that they needed to keep themselves protected.
I saw a video that was taken at a hospital where there were a number of COVID patients on ventilators, and all you could hear was the beeping and people rushing around from patient to patient trying to save lives. With that number of patients and just the confusion, the coordination that's required to take care of those patients even has got to be. I mean, you're switching. You're not just switching patients, but you're switching patient issues, right?
Absolutely.
Patient on ventilator A might be young and otherwise healthy. Patient on ventilator B could have some really serious underlying health issues, and as soon as the beeps and the bells and the signals start to go off that says that somebody's having a problem, you've got to switch mindset in order to race to that person. So then I'm thinking, and I know you guys think of this too, what about the PPE that you're wearing? I understand that, I should be able to cite exactly where I read it, but that the germs on, say, a surgical mask, COVID germs could last for a long time. And if you're going from patient to patient and trying to care for everyone, do you have time to change a mask? Do you have a mask to change into? So do you sometimes feel helpless?
Absolutely. And I think that your kind of recounting brings up a couple of different things. So I want to assure people that the individuals that are running these ICUs are exceptional. And so, what may seem like chaos, there's actually an organization to it. The ICU staff are some of the best in the hospital. And so they being our front lines and caring for the different patients on different vents. And, they're doing a tremendous job. Now, you're absolutely right to point that out, though, because what happens when those kind of frontline individuals who are used to that environment get sick? And you're bringing in replacement doctors who maybe don't do that kind of work, but do different kinds of work. Medicine is highly specialized, right? Like I'm an HIV primary care doctor.
Right.
I'm not a vascular surgeon. I'm not an ICU attending. But if there's no one else, I'm a better person to put into the ICU than, let's say, the kind of layperson that may not have any of this knowledge, right? And your point of how do you take some of these individuals and maybe less expert in this environment and switch them from patient to patient to patient, we have to worry about some of the kind of, I don't want to say errors, but just some of the kind of learning curves that we're going to meet as we're kind of bringing in more people as the front line gets sick, which is why it matters so much that we get individuals PPE. I think exactly as you've said, not being able to change between patients, that happens more or less, I would say, like in an emergency room environment where, again, the kind of inflow is really, really rapid. For the most part, what we're seeing is that if the majority of patients now that everyone's seeing is COVID positive patients. And so, thankfully, we're not taking it from someone who isn't COVID positive to someone who from someone who is COVID positive to someone who isn't. But in an ideal world, would you stop, decontaminate, change your gowns between each patient? Absolutely. And that's why, again, it matters that people stay home, because then we don't see the crazy numbers of patients we're seeing, that our PPE is enough, our staff is enough, and we can kind of do things the way that it should be done. If you're in a war zone and patients are coming in and they're really hurt, you're not going to say, have I had time to do this procedure X, Y, and Z? Someone's bleeding out in front of you, right? This is, in some ways, somewhat of an equivalent. And it just means that we can't give the exceptional kind of medical care that we all want to be able to give. And it's why it matters so much that we get these numbers under control and don't hit the surges that we're all afraid we're going to be hitting.
Let me ask you about the numbers of deaths per minute, or every 3 minutes in New York, increased. How is it possible? It obviously is possible, but I'm trying to think of the impact on losing a patient, on the doctor or a clinician when they're working on someone and they lose them and they have to go to the next person. I can't imagine the emotional roller coaster that everyone there is on.
Yeah. Absolutely.
Is there time to take a deep breath?
You're just going from the next person. It's at the end of the shift that you're really feeling all of this. I think what's really important too for what you've just described is not just, your patients die not infrequently in medicine, right? It's just part of the way, it's part of life and death, fine. But with COVID, part of what's so difficult is that these patients are dying alone because the disease is so infectious. We can't have family members there. And so, I haven't yet kind of been in the ICU settings where this is happening, but colleagues have told me the hardest thing is watching someone die alone, having FaceTime, for instance, with their loved one. And, a lot of these people as they're going are totally, out of it. They're on high dose pain medications and other medications, and their loved ones FaceTime and see them, as they're passing away. And maybe you might be the only, as a clinician, as a nurse, might be the only person in the room, kind of shepherding this person into as they pass away. And so it's not just that people are dying so frequently, it is that the ways that people are dying alone is so traumatic to watch. I think to your earlier question is why we should expect to see quite a bit of just mental health trauma from all of this, and I think it's going to be really, really difficult. The other point too is we all were told when this was coming from other countries that this is a disease of older people. And the number of young people that I have heard about, that I see coming in, some of whom get intubated and then die, is really staggering. So this isn't, it's a falsity to think of this as a disease if just old people or folks with underlying health conditions. This is really strangely hitting wide swaths of the population. And so we're all at risk. And it's something that is really hard when you're watching a 40-something-year-old die, with a young family at home that can't even come visit.
Yeah. There are probably an incredible number of people who have COVID who are at home. How are they being cared for? Or how do they receive information about how to take care of themselves?
Yeah, and that's where I think the primary care force has really stepped up and been strong. In New York City, when COVID hit, what the primary care ambulatory sites basically did was they shifted the practice model so that we provided telehealth and telephone visits, and individuals could call. So instead of people coming in, because again, we thought if you come in, you have COVID, you're sitting in the waiting room, even if we give you a mask, there's a chance that you're going to be spreading it all over. So because of the way the disease kind of manifests itself, where the majority of people are mildly ill, let's see if we can have a model where if you call and we confirm that your symptoms are COVID, we give you kind of instructions on how to take care of yourself at home. You stay home, you quarantine, you tell anyone who you've come in contact with to quarantine, and you go from there. That is the way that our model has had to do it because of one very, very big mistake that we made. And we being the U.S. healthcare system, which is that we don't have enough tests. If we had enough tests, this would be a totally different approach to the disease, right? Because we don't have enough tests. We've just basically told people don't even bother coming in because we can't even test you and confirm and do more once we've tested you. So the model now is just, you call, you get told, yes, this is likely COVID. And it's even moved from that. It's even now, they say, don't even bother calling, just know that you probably have COVID and take care of your symptoms, right? What's really dangerous about it and what we're hearing about in New York today is that they believe that once you start to really look into this, that a number of people who have COVID symptoms are likely dying at home on their own and never make it into the emergency rooms to be evaluated. And that's just devastating, right? That's just absolutely devastating that that's kind of where we've gotten to. I would say from a public health perspective, the thing to know is that, yes, if you have a cough, fevers, shortness of breath, you likely have COVID. It's really important if that shortness of breath is getting worse that you come in right away, because the time that you're feeling it kind of progressing, the time that it could become super kind of problematic is fairly short. It's a matter of half a day to a day. And so it's important that you come in and get evaluated before it's too late for you to really be able to get the help that you need.
I've also read that COVID is devastating, that once you can't breathe, that you're tired, your whole body feels heavy. For people, say, in anywhere, but, in New York, if you live by yourself, it could be that you can't even make it to the bathroom. How would they get their medications in order to self-medicate if they can't even get off the bed or off the toilet or out of the bathroom, or they're sweating profusely, they've slept for days, they have no food in the house, they can't cook, they have no energy, nobody's going to take them, the ambulance is probably not going to come, right?
Yeah, for the most part, if you're that sick, our hope is that you'd call an ambulance. If you're in New York right now, all you hear are ambulances all day. The ambulances are the ambulance kind of technicians are incredible. They're the unsung heroes of this. They've been going out and getting patients and bringing them in. So if you're that kind of unable to deal and you have no support, you have to come in, because exactly as you're kind of intimating, it could get really bad and no one's there, right? For the majority of people, we hope that what happens is if you can't kind of go out and get what you need, you have a family member or someone who can kind of bring it to you. COVID's one of those diseases. It's an isolating disease, but it's also a disease that really shows us the importance of our social networks, because exactly as you've suggested, if someone can't do it for themselves, we don't want them out there in the grocery store trying to buy groceries, right? It's important that we're able to bring that to them. And so, it's one of the reasons why I've been kind of telling everyone who will listen, it's important you check in on your peoples. If someone says, I have a fever, I have a cough, text them many times a day, make sure they're okay, ask them if they need anything, whatever you can do to kind of help them out. This is the time it really matters. Not only will you make sure they're okay, but you'll also kind of maybe hopefully keep them out of the emergency room where people who are even sicker, are going to be going for help.
So many bases to cover, and we're all so unprepared for this. We're just learning by the seat of our pants, all of us, right?
Mm-hmm.
What's the most disturbing thing that you see, say, on your way to work, right? So right now I'm in California, and we've been basically sheltering in place. I actually live in New York City, in Harlem, but here I haven't been anywhere since January 26th. Nowhere. Wow. Nowhere. In New York, though, I know that people are out. I don't even go out for a walk because I have both of my parents are elderly. I don't want anything floating in the air and put their lives at risk, right? So I've not been anywhere. But if you live in New York and you go for a walk, what are you seeing about people's behavior? Have they changed it?
Yeah, it's a great question. I think they changed it, and the city has forced us to change it. So if you go to the playground where people were congregating before, even when the shelter-in-place orders went in, they were open and, people were playing basketball. The mayor and the governor are not playing with us. They have taken all the basketball hoops off. So you go to play basketball, there's no hoop. They have padlocked all the playgrounds. And so the places where people were congregating before, you really can't congregate there. The police are out, and they are asking people to kind of turn back. But to your question of what's the most disturbing thing that I see, the most disturbing thing is that the buses and the subways are still full. And they're full of Black and brown people who are heading to work, to jobs that they cannot not head to, right? In New York is a unique environment because we don't have cars. We get around by public transportation, and the city in some ways still has to function, right? These hospitals, who are the ones who are cleaning the hospitals, who are serving, as clinicians, who are cooking in the cafeterias, they're individuals that live in the Bronx and Brooklyn and have to get into these hospitals to work. And so the hardest thing for me is seeing all the people who are, heading over to the subways or seeing the buses pass by and they're still pretty full. And yes, most people are wearing masks. But, it'd be ideal if we could really kind of keep everyone inside and keep everyone safe. I'm hearing about people who know that they've gotten sick from having to take the bus. And it's why we think that we're going to see higher cases of COVID among certain communities, because these communities probably couldn't really follow through with sheltering in place because of the fact that they had to, go serve their UPS shift or go and work, in whatever capacity they have to work. So I think that's probably one of the hardest things to kind of witness at this point.
Yeah, and I've heard also that in other urban areas that it is Black and brown communities that are hit the hardest by COVID as a result of them having to go to work, not having the luxury of sheltering in place, but having to put their lives on the line to continue to support their families. And quite honestly, to support the rest of us, because the bus drivers, the train engineers, I mean, they're all putting their lives on the line to be sure that things keep moving, but they're at such great risk.
Right.
And they go home.
Right. And they don't have, and when they go home, maybe it's multiple individuals that are in the house with them.
Yes.
And so they can't socially isolate. I think someone kind of said it best that, social isolation is a privilege, right? Social isolation, rather social distancing, being able to do that is a privilege. You kind of talked about kind of the impact globally. Think about all these places in India and Ghana and other places that won't be able to just kind of follow the instructions to socially distance. We're seeing the same things in parts of the Bronx and Brooklyn and other areas in New York where we're asking people to kind of, spread themselves far from their loved ones. But how can they when it's 6 people living in a one bedroom or a studio, right? So I think you're right that these individuals are going out to risk their lives to keep society going, and their living conditions may be such that then they're spreading it to their families. So it's really tough, I think, on multiple levels.
Yes. There are 2 more questions that I'd like to ask you.
Sure.
And I hope I can get it all in. I know thank you so much for giving me this time. So we spoke about, or you mentioned sort of racial disparities. And we were talking on our lead up to this interview about the racial disparities in healthcare. And then, of course, the first thing that comes to my mind is the whole issue with ventilators and someone having to decide who lives and who dies. And I know that we were going to have this as a separate conversation because it's really deep.
Mm-hmm.
But help us understand just a little bit of that process, if you would, and how we could protect ourselves from people who maybe might be clinicians and or doctors, and they have their own biases, right?
Yeah. So, I think the issue comes up because we're going to be in a situation where in some areas like New York, where we may not have enough equipment for the patients. And so what professional societies like the American, Well, so all professional societies will kind of make recommendations on this, but really what we follow is the recommendations of our hospital system. And so you'll get local recommendations that go out about how to evaluate equipment, allocation by patients' kind of likelihood of being able to pull through. We know if you have COVID and you get placed on a ventilator that your mortality rises significantly. 2 out of 3 patients that are on ventilators who have COVID will actually die. And so what will happen at that point if ventilators are running out is that the clinicians who are working with those patients will evaluate different patient characteristics that'll help them figure out, who gets placed on ventilators. This is not a death panel. This isn't people kind of deciding, well, you have, you're going to live or you're going to die. It's more, if we have multiple patients at once, who have, factors that differ according to age, underlying medical conditions, even things like, what you want to do in terms of resuscitation, et cetera. All these things get placed together to decide, how that happens. Those decisions, I think I was mentioning that, they happen not by a single individual, but usually by a group. And so, an attending clinician with backup from another attending clinician will really try to make those in tandem so that it's less kind of likely to be based on one person. If a hospital system is really overwhelmed, you can imagine some of those processes don't get followed as much as they need to. And then I would say, it's really smart of you to be thinking about how we can all advocate for ourselves. So if you're a family member who's, knows that someone you love is going to go into the hospital and there may not be enough ventilators, I would say the most important thing is to make sure you're really clear on who's treating your family member and that you're calling and being in touch and asking them these upfront questions of what is your hospital's policy on ventilator allocation? I think even just hearing that you understand that that's a thing lets people know that these decisions have to be made in a way that follows clear guidelines and documentation. And I think just really being able to advocate for your family member at that point, it comes from being able to ask questions and being able to follow through. I want to reassure people that these decisions don't get made lightly, that there's a lot of guidance that goes into them, but systems are imperfect. And so it's going to be important, especially for vulnerable populations, underrepresented minorities, to really make sure you're advocating for yourself and your loved one.
And to have that healthcare proxy, not that they have time to check it, but to have it in place and to let your wishes be known, right? Yeah. This is a tough time. Dr. Stella Safo, thank you so very much for joining me. I know you've got to go see the patients. I'd love for you to come back because there's still a lot more to talk about, but I really thank you for giving me this time today.
And thank you for what you're doing to keep folks informed.
Oh, I appreciate that. This is hard. It's hard. I have tears every time I read the news. Every time I speak, it's hard. It's hard.
But we're going to pull through it. We pull through it together,
Yes.
And by sharing information.
Indeed. And thank you very much for joining me.
You're very, very welcome.